Morning.
My word, we've got an enormous class today.
I know. It's pretty rare I sign in and there's nobody in the room. Big group.
A lot of people away on holidays, I think.
I reckon. Man, it's tempting to be away from on holidays myself, actually. Are you on holidays, Jeff, or are you around?
Sorry, what was that, Anna?
Are you on holidays or are you in Sydney?
Well, I'm sort of semi-permanently on holidays. I'm in Sydney here.
Yeah.
Um, yeah, I've got some local work organised at Arimba
Oh, cool.
months, a little bit, and
Yeah.
my usual Canberra trips.
Yeah. You're not dabbling in horsework, are you?
I'm not.
Dabbling in horsework at
Oh
a
no, 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 not at all. Gave that
probably
away
wise.
decades ago.
Yeah. I think we've got a couple of new people today. Nicole, hi.
Hello, how you going?
Well,
Yes,
thanks. How about you?
very, very new.
Yes, excellent.
I'm,
What's your background?
I'm at JCU
Oh,
Uni,
cool.
medicine intern here. My boss, James, might step in as well, but I told him about your Zoom tutorials and he was very interested.
Oh,
So
cool.
yeah, we thought,
Yeah, awesome. James who?
James Foster.
Okay, right.
Yeah.
Excellent. Um, so I usually like the way I like to teach is just asking questions and making it quite conversational. I won't target you specifically because you're new. Lauren, you too. But you're very welcome. Just like it's very casual. You've probably seen them been here before, and I've just been
Hmm.
with people.
Yeah,
Yeah.
great.
Don't feel like I'm going to deliberately target you or anything like that, but please do feel free to get involved, even if I'm not asking you questions specifically. To
Perfect.
achieve a fair game, I'm going to target you.
What was that?
I'm going to target you with
Oh,
questions.
target me. Okay. Good morning, everybody.
Not specifically, of course.
No, I
Um,
know, I love it. It's like absolutely my highlight.
oh, I'm so glad. It's so nice to hear. Um, so the subjects today are very emergency critical care, which I don't even work in a clinic anymore, so I don't see these cases anymore. So I do want you guys to like throw case stuff at me and like clinical presentations and stuff like that because I love the pathogenesis and etiopathogenesis of sepsis, SIRS, and anaphylaxis because that's very medicine-y, but and it applies to so many other conditions as well. So I will definitely go too deep in this, but please feel free to drag me back into the clinical land. So I thought we'd start with sepsis and SIRS. Um, was I supposed to go over anything that we didn't get to last week? I don't think so. Last fortnight.
I don't think so. Don't know.
Yeah, I don't think so either. Morning, Maya. Okay, good. So yeah, let's start with sepsis and SIRS. What's the definition of sepsis? Let's say
Sepsis or SIRS?
sepsis, please.
Like it's an overwhelming infection because of bacteremia, but then should you also have a systemic inflammatory response to
Good.
that to call it sepsis? I think it's a very overused word.
I don't know. I really like having a term for the clinical presentation as opposed to the cause. So, like in an emergency setting, you have to treat the clinical presentation that's in the crisis without worrying too much about like the why. Like you've got to keep the why in the back of your mind, but you've got to put out the spot fires kind of thing. So I think it's a really nice classification. So sepsis, as you said, bacteremia with systemic inflammation or an infection causing systemic inflammatory response. So an infection that hasn't kept its inflammation confined to a local area. So even if the bacteria aren't in the bloodstream, it's usually caused by infection.
Bless you.
So that's sepsis. What about SIRS?
With so it has to satisfy two of four criteria:
Right.
high or low body temperature, above 39 or below, what was it? God, I've forgotten.
Actually, different for
but-
dogs and cats, but
Yeah, it's different for the two. High or low heart rate. Dogs I'm referring to.
yeah.
High or low respiration rate, or high respiration rate rather, and high or low body temperature, plus a high white cell count, or a low one, or more than 5% band. Wait a minute.
Absolutely perfect. Did you read that, Jeff?
Yeah, just before we started.
I was like, that's amazing. Well done.
But I sort of knew it before because it used to be one of the favourite questions when we're examining in emergency medicine.
Yeah. It's actually a nice question because it's that, as I said, it's that syndrome that if you meet these criteria, you need to go down this pathway of management and investigation. So it is kind of a nice thing to have in the back of your mind. And the reason why I keep wanting to come back to clinical is, as I said, I'm not in an emergency clinic at all, but I do get called out to do emergency ultrasounds in really sick patients often. And the vets in general, we want to know why so we can treat it specifically. And I think particularly in general practice, it's very easy to overlook that emergency management requirement because you don't really understand what the cause is. So I really want to differentiate that. Like, yes, we can come and do an abdominal ultrasound to find the source of infection, but you needed to put this dog on antibiotics yesterday. You know what I mean? Excuse me, sorry. So what do you think? I haven't actually seen any data on this, but what do you think about the criteria of sepsis or SIRS that Jeff described? Are there any holes in that classification scheme?
Well, cats are different.
Yeah, quite.
Very vague. I think not the easiest to identify because it's pretty vague.
Yeah, it is. And there's a spectrum, isn't there? There's a spectrum where like there's an infection and there's a little bit of inflammation and maybe like borderline pyrexia, and they haven't quite met those criteria. But they're on the way. And what about the neutrophil? I guess there's a couple of little like caveats in there with the neutrophil count or white blood cell count being high or low or bands. But how many people are seeing blood tests being run on in-house machines that will call neutrophils normal and lymphocytes high in an acute presentation setting?
Definitely have. And that's why you have to look at a smear because then you realize that what the machine's reading is actually incorrect. It's reading either bands as lymphocytes or macrophages as lymphocytes because of the size.
Yeah, completely agree. So I'm always suspicious of a normal lymphocyte count in a sick dog. There should be a low lymphocyte count in a sick dog. Why is that? Why should it be low?
Stress response.
Yeah, stress response, exactly. So sick dogs should have more cortisol, which will cause a lymphopenia. And if there's an absence of a lymphopenia, there's either misreported some other cell's been reported as a lymphocyte, or they're sick from Addison's disease, not sepsis. Something like that. Or they've got
Addison's disease can present like sepsis.
It absolutely can. Oh man, I had a cracking Addison's case.
Oh, tell us.
It's a dog that presented, I'm sure I've talked about this case before. Dog that presented with nasal discharge and a neutrophil count of 28. And we did a CT and ended up doing some biopsies because of quite diffuse changes. And quite an acute onset nasal discharge. Did some biopsies, came back then for plasmacytic rhinitis with like quite a lot of neutrophils in it. And I thought this neutrophilia doesn't really make sense. Like I've never seen an LP rhinitis with like that degree of inflammation. Maybe it's a secondary bacterial infection, blah, blah, blah. And I was kind of like umming and ahhing what to do with this case. And I was talking to the owner, the biopsy results, and he's like, so what did you find with the diarrhea? And I was like, you didn't mention diarrhea. What are you talking about? And I went back and looked at at this dog's bloods, and he was normal lymphocyte count but with this neutrophilia, which meant that Addison's wasn't on my list at all. His sodium was low. I was like, oh, I really didn't notice that in the context of the nasal discharge. So annoying.
So then was this two separate problems? How do you link the two?
I don't know, but I think he was probably immunosuppressed or like his immune system wasn't functioning well because of his Addison's, and he got a nasal infection.
But
And the
then you said
diarrhea
he
was
also had LP, rhinitis, like on biopsy. So then,
Yeah.
like that would be a second second thing, right? Like, because infection, maybe yes.
Then if you've had a chronic infection, you're going to have lymphoplasmacytic inflammation eventually.
Okay.
So over a couple of weeks, you're going to get LP infiltration just with chronicity. Yeah, it was a
Cool.
confusing case. But
Anyways, you treat with pred anyways, so
yeah,
at the end
nobody
of
wins.
you come back to pred. The
Fix
circle.
everything.
Why do we even test?
Yeah, that's why everything is so frustrating. Okay, excellent. So we've got a definition. Oh, that's what I wanted to talk about actually. CRP. Has anybody seen any data on the role of CRP in this like classification for SIRS or sepsis? Hasn't made it to the textbook yet, and I think it's an omission.
I'm not aware, but CRP, at least my understanding is it's so non-specific. It's such a non-specific inflammatory marker. It can go up with literally anything. So not really like to use it as a one-time point to make any, like you can't really diagnose with CRP. If it has, I mean, it does have some value maybe in monitoring treatment, response to treatment rather.
Yeah. And I agree, it's not going to be very good. Like if you're not going to call a dog septic if it's got like just because it's got a high CRP, they have to meet these other criteria as well. But I'm probably going to call it non-septic if it's got a low neutrophil count. For example, a couple of the other parameters that are normal CRP. So it might just, if particularly in those, because neutrophil counts, right? If you get an acute inflammatory response and the neutrophil count goes low where they're being consumed, then it goes through normal before it gets to high. And particularly if you can't trust your in-house blood machine to accurately report percent of bands, there's going to be a period where we're missing some of these patients, or they might have a normal or low neutrophil count, and you need to differentiate them. And that's where I think CRP might have an application, because it should be through the roof. If they've got that degree of neutrophil consumption to end up with a neutropenia, then their CRP should be very high.
So when I finished vet school, I used to think bands equals infection. But now I know like bands is not always infection. Bands can also be high with inflammation.
Yeah, absolutely.
So then to distinct, like, because it's always in my head, I'm like, not necessarily sepsis, but generally speaking, I'm like, oh, should we start antimicrobials for this specific case? And it's always like, I'm always debating because I try to practice antimicrobial stewardship as best as I can. It's always, when it's in the gray zone, it's always like, oh, what do I do with these information with the bands? Because it could still just be inflammation. And do you have any tips and tricks to, like, how do you tease this out a bit?
I find this very difficult, very, very difficult, because like with you, I feel like we've got an obligation to be responsible with antimicrobials, but as opposed to the medical profession where they've got the ability to test for infection in a variety of different ways and be more selective about the patients they give antimicrobials to, we are at the discretion of the owners as to whether they want to do that testing or not. And I think then we have to make a judgment call so often without enough information. So I think it's a really difficult position. I think it's a big stress for me as a clinician, is that walking that line. Yeah.
And you can have SIRS without infection.
Yeah, absolutely. For sure. What would be the most common inflammatory condition that causes SIRS?
Pancreatitis.
Yeah, for sure. Yeah. Really bad pancreatitis, most common. Okay, well, that's a good segue into what the triggers are for like bacteremia sepsis. Let's talk about that separate from SIRS if we can. So where are the most common sources of infection in dogs?
Bladder, young dog lungs, then go for spine, and then anywhere.
Gut.
It's a very all-encompassing answer, and I can't say it's wrong. So bladder for sure. So bladder, gallbladder, lungs are the three that are sometimes hard to identify. There's papers that have said liver enzymes will always be elevated if there's active liver inflammatory change in the liver or infection in the liver. But so many dogs have elevated liver enzymes like normally. And actually ultrasounded a dog with a normal ALP, normal bilirubin, raging neutrophil count. And it's like all of the inflammation was around its gallbladder, and I didn't know what it was, but it looked really abnormal. And I just said needs surgery. Like it's got a like septic abdomen basically. Took some fluid and blah blah blah. It was surgical, but I said in the surgery you need to be prepared to take out the gallbladder because it looks really raunchy in there. And it was an abscess in the gallbladder with completely normal liver enzymes. Like full
Walled off
walled off, yeah.
in the gallbladder.
Ew. But like yes, sometimes you can't rely on liver enzymes. As I said, like it can be elevated in cases that aren't associated with whatever you're seeing infection wise. But also can be normal in case of very severe hepatic or biliary infections. I've also seen dogs with necrotic infected liver tumors with normal liver enzymes. Can't rely on them 100%. And I'm always like, who ran this blood? Was it the right blood? You've got the wrong patient, which is also possible, but it's important to consider. So yes, dogs are typically abdo and pneumonia. What other source would we see in a cat?
Oh, cat bite sepsis. Cat bite.
Cat bite, exactly. Yeah, for sure. So like subcutaneous abscessation, but also pyorthorax, often from flight wounds as well. And they can hide that pretty well because sometimes it's pretty low volume when they're showing signs of sepsis and they're not actually got respiratory signs, but they are septic. So pleural space. So when I get called out to do an ultrasound or investigate a patient with signs of sepsis, like who's met the criteria for sepsis, I really want to do a urine or want to see a urinalysis to help rule out urosepsis. How common is it to get signs of sepsis with a urinary tract infection, uncomplicated lower urinary tract infection? Rare.
Uncomplicated. I would think none.
Very
Or
rare.
very, very low.
Very low, exactly. It's only really if you've got really significant hematuria and translocation of bacteria theoretically into the bloodstream. And whilst we're talking about sources of infection that cause the signs of sepsis, what type of bacteria would be most commonly associated with signs of sepsis?
Gram-negative.
Yes, amazing. Yeah. So certain organisms will have a pathogenesis that it predisposes to causing sepsis more commonly. So if you've got a really bad E. coli UTI that's really enteroinvasive, not enteroinvasive, but invades the epithelial cells within the bladder, then you're more likely to end up with a urosepsis. And then again, those organisms that have the ability to ascend the ureters and go into the kidneys, again, much more likely to end up with urosepsis that way. We are going to get more into my favorite part, why E. coli or gram negatives are more likely to cause sepsis than other organisms. So what other organisms other than E. coli have you seen associated with sepsis?
Could be other gram-negatives, but
Yeah.
Pasteurella, like from cat bite abscesses.
Yeah, for sure. Yeah. Anaerobes, I reckon, big one in necrotic tumors and stuff. And do you guys, so that's sort of the bacterial organisms that we see most commonly. Do you guys have any feel for how sick a patient is with like a gram positive versus a gram negative?
Like just maybe gram-negative Zika, maybe.
Yeah,
It's not
these
based on any side. Like
are more acute.
Is it because it's got is it the LPS, the
Yeah.
endotoxin?
Exactly. Yeah. So I think I remember this best through uni talking about endotoxemia with horses. And it's all the same mechanisms, but I don't know why it's taught so differently in dogs and cats. But the lipopolysaccharide triggers this just really profound inflammatory cascade really acutely. So the infections are usually like crashed and burned, like a healthy dog yesterday and really, really unwell today. And in particular, if I'm looking at a patient that I'm thinking there's the biliary system's the source of infection, E. coli is one of the most common organisms to get into the biliary system, but so is staph and Clostridia, and they're never as sick when it's staph and Clostridia. And so I'm kind of looking at their presentation and looking at what antibiotic I'm going to use as a first line, either without doing a culture because there's risks associated with cholecystosis, or if the culture comes back negative or while I'm waiting for the culture. If they're really, really sick and they've gone down in 24 hours, I'm more likely to reach for fluoroquinolone as a first line. There's very few situations I'll do that, but if I'm seeing biliary action, biochem and clinically and on ultrasound in a dog that's gone downhill in 24 hours, or a cat, I should say as well, with all of the signs of sepsis, I'm much more likely to reach for fluoroquinolone than CLAB, for example, which I would do if they've gone down over the course of a couple of days and then maybe temperature's not that high and they're still eating a little bit, sort of thing. All right. So good. Oh, what other organisms? Not bacteria.
Aspergillus count?
Fungus, yeah.
Yeah. Has anybody ever seen a systemic aspergillosis?
Recently.
Yeah.
Yes.
How
Seen-
acutely unwell were they?
Came in with bilateral retinal detachments and was fine.
Mm.
And then I referred it to internal medicine and then called it back when the results came back. And apparently they lost all this weight and was really unwell. So I think it was maybe fine for about a week. It went blind, but was systemic okay for about a week.
Yeah.
And then all of a sudden started losing weight and
Mm.
feeling really unwell. Like we had to convince the owners to even do bloods for the retinal detachment because they were like, no, he's fine, like otherwise fine. And then yeah, fair enough. And now it's also affected its spine, so it can't walk properly. And yeah, very sad. And I saw another one at Sash once. I think that one was more acutely unwell, but it was like a big German Shepherd that I could lift with like one hand. It was that skinny.
Oh, wow,
It was really sad. Yeah.
I think they seem to they've got a history that's been going on for a while, even if they've only been like unwell for a short period. It's like they've been losing weight and subtle things have been going on, like all the fungal. Yeah, I don't know. When you look back in the history, there's something.
Yeah.
Yeah, I agree. And it's usually over weeks rather than like 24 hours that they've become unwell.
Yeah.
It's pretty typical of like fungal septicemia. And Aspergillosis penicillium species are the most common that we see systemic infections with. And typically it's in immunocompromised patients, like we've sort of mentioned shepherds who have a genetic predisposition to Aspergillus infection. Aspergillosis, yeah. So they're more susceptible, and then other patients that are on immunosuppressants are going to be more susceptible to septicemia with organisms other than bacteria. So if I'm looking at a patient that's got signs of sepsis with a few weeks long history and happen to be on cyclosporin for something else, then I'm going to be thinking, oh, I'm probably not just going to reach for an antibiotic and chuck it at it. I'm going to say it's been sick for a couple of weeks. Let's do fungal bacterial cultures and see what we're dealing with here. And a wider search for the source of infection so that we can be more specific in our treatment. What other organisms? Cats.
Oh, Pasteurella.
Oh, no, not bacterial.
Oh, Cryptococcus.
Oh,
Crypto. Yeah. Crypto, again, rarely causes systemic infection.
Boxo? Does that
Boxo.
cause?
Boxo can do anything.
So that's what I'm thinking. Protozoal infections. So typically protozoal infections will do the crash and burn presentation if they're an acute infection. So much more similar to a bacterial sepsis. it can be really hard to differentiate actually, apart from that typically they're immunosuppressed patients. So it might be a patient with an IV or patient on immunosuppressants for another reason. What about neosporosis? Has anyone seen that in dogs?
That's a really
Yes.
bad outcome though, usually. Like, I don't think you necessarily get rid of them and rid of Neospora, and it's a really bad outcome.
I saw one who looked completely healthy and was in for something routine, and when I looked through its history to make sure there's nothing I needed to be aware for that, instead I had Neospora as a puppy and miraculously recovered.
Oh yeah, so that's a little bit different from the acute presentation. So you can get transplacental infection of neosporosis, or you can get acquired neosporosis as a yeah. So that acquired neosporosis is a systemic infection, whereas neosporosis in puppies typically ascends the nervous system and causes spinal rigidity and spinal. So they're actually quite like not very unwell with neosporosis. It's transplacentally acquired. So I've seen systemic neosporosis twice in dogs that I had on immunosuppressants. One was for SRMA, steroid responsive meningitis arthritis, and one was for IMT. So both on steroids, both fed raw meat from their owners, despite being told specifically not to. And acquired systemic neosporosis, and I couldn't differentiate between a bacterial septicemia and a protozoal. So just have it if they're coming in crashing and burning, and then maybe immunosuppressed for another reason, could easily be bacterial if they're immunosuppressed as well. But have in the back of your mind, like this might be a little bit more complicated.
And where did you find it in the end, or did you do serology? Because that takes a while.
It does. So the first dog came up with skin lesions, like rupturing, like pustules kind of thing. And we actually just did an impression smear of one and sent it to the lab, and it had spore organisms in it, which was pretty cool. So they were really like, that's such a good advertisement for having a good relationship with your lab. And the second good advertisement for that was a dog that came in on pred and was really affected in the respiratory system. But the pattern of radiographic changes was a very kind of hematogenous pneumonia rather than a like aspiration or focal lobar pneumonia. And I was just suspicious it was going to be something weird. And the other thing was the ALT was disproportionately higher than I would expect with a systemic sepsis without any focus of infection in the liver. So I called the lab and said, I need you to run a neural PCR on this blood. Will you do it? Because PCR detects genetic material, right? If you get a positive, it's not going to be a false positive typically. Like I wasn't sure whether it would come back like false negative, but if we got a positive, we got a positive. And they were like, yeah, sure, we'll do it. And then they did it and they quantified it and they got really interested, and then they ended up optimizing their assay for use in blood. So now it's part of their infectious disease screening titer. So definitely worth a phone call and see what you can do. But we got a positive on PCR, which was a 24-hour turnaround, which was nice. And interestingly, we're jumping right through pathogenesis.
Well, I have a question, Anna. Sorry.
Yeah, go for it. Yeah.
Because I've had this in my head for such a long time, but I just can't find the answer. Why is it that in Neospora we only check IgG? Because IgG is usually like latent infection. IgM is more active. But yet, when you send your serology, it's only checking IgG. So it really, whereas with Toxo, you can do IgG, IgM. But Neospora is only IgG. So why?
They probably just haven't developed the assay. We only fairly recently discovered that the dogs that we thought had Toxo actually had neosporosis. So it's quite kind of like the testing for it is still evolving.
So would you get a false positive if they had it as a puppy from the transplacental route?
Yeah.
So would you send a PCR and an IgG then?
I probably wouldn't even bother with an IgG.
Okay.
Yeah. I mean, yes, for sure. Like if you're doing an exam, anyone doing memberships definitely write IgG. But I think like the value in that, like if that dog came back with a positive PCR and a negative IgG, I'd go, great, this is an acute infection. Let's recheck it again in 3 weeks and confirm our suspicion.
Track the IgG.
Yeah. So there's no way I'd rule out an acute neosporosis, but on a negative IgG, I'd definitely repeat it again 4 weeks later. But you're exactly right, 5 to 7 days before we see any IgG. And they're fully sick by then. My gosh, they're really bad. Yeah, so typically the protozoal infections, like the ways that little things that you might see that make you suspicious that it's protozoal, they cause like hepatitis, pancreatitis, pneumonitis. So you get like quite profound like parenchymal deposition of organisms. And they're essentially in, sorry, my naughty dog, multi-organ dysfunction. And it's quite like you see those like the ALT is just going dunk, 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 dunk over the days. And interesting, I was going to say with Neospora, both of those cases actually came good. So they had a complete recovery. One of them, I thought like it was awful to watch because they'd declined ventilation and the breathing was so bad. So we had it on supplemental oxygen for like the nasal prongs. But they wouldn't go to ventilation. And we had this like 24-hour period where no one could watch this dog breathing because it was so distressed. But the owners wouldn't consent to euthanasia, wouldn't consent to ventilation. And in hindsight, I'm like, well, they were right. Actually, they were right. It was worth it, but it could have gone either way. Yeah, I spoke to Richard Malik about that case. And typically we use clindamycin with protozoal infections. It was like, I don't know who published that, but it's rubbish. TMS for both Toxo and Neospora. Readily available, easy to access, awful to dose if you're a cat, but it's much cheaper as well for people that can't afford clindamycin, and much more likely to clear infection than clindamycin on its own. With both of those cases, we ended up getting another antiprotozoal medication called pyrimethamine, I think.
Yeah.
Compounded, yeah. So we use that in addition to the TMS, but the TMS got them out of trouble in that acute setting. Okay. So let's then talk about how different molecules, antigens, cause an inflammatory response. Does anyone know? What's that like molecular pathway where sorry, I'm going to go way too deep. Got blank faces.
Do you mean like they release cytokines and attract inflammatory cells? Like, what do you mean?
Well, there's a specific kind of inflammatory pathway that I think is really interesting because it's involved in the pathogenesis of IBD and a lot of autoimmune diseases. Has anybody
Lack of self-tolerance, is that what you mean?
Sort of, except in this case it's very appropriate. Same pathway in terms of like the inflammation that gets generated. Has anybody heard of danger-associated molecular patterns? No?
I think I've heard of it, but like, yeah, I have no
Somewhere
idea.
in the archives.
Yeah.
So there's like microbial patterns or like protein patterns and things that trigger the body to have an inflammatory response. So that's without ever having seen an organism before. That's how an immune response or an inflammatory response is generated from an organism. Different organisms have like different markers on their surface that trigger that inflammatory response. So for example, lipopolysaccharide on a gram-negative organism is very recognizable to a human that's never seen a gram-negative organism before. Like, so obviously we've all got gram-negatives in our gut and stuff like that, but we're all born with a pattern recognition receptor for lipopolysaccharide in areas where lipopolysaccharide shouldn't be. So like in our bloodstream, our tissue macrophages shouldn't be seeing bacterial antigen. So if a lipopolysaccharide flies past this pattern recognition receptor, sticks to it, and triggers a sequence of events that then causes inflammation to develop. And different molecules have different degrees of reaction associated with them. So gram-negatives, the lipopolysaccharide, triggers a really profound inflammatory response through that pathway, whereas a gram-positive molecular pattern doesn't trigger as profound a response. So we typically get increased pyrexia associated with increased inflammation. So more dramatic, all of those parameters that we use to diagnose sepsis, all those parameters are more extreme depending on how triggering that molecular pattern was. Is that too deep?
No,
Make sense?
makes sense.
So where this like then kind of crosses over into IBD is those pattern recognition receptors are expressed in areas that shouldn't be seeing antigen. If they start being expressed on the surface of the gut, or if the surface of the gut is breached and the underlying tissue is exposed to luminal antigen, you're going to get this chronic rumbling inflammatory response. Make sense? So once those pattern recognition receptors, the danger-associated molecular patterns, trigger a pattern recognition receptor that lives on the host cells, and that activates macrophages and neutrophils that happen to be in the area. And then we get that cytokine storm that Simone mentioned. Simone or Maya, sorry, I can't remember. So then we get cytokines and like nitrous oxide and leukotrienes and all of those like inflammatory mediators getting released. What happens then? Why are
Worsen inflammation.
you get more inflammation? Yeah.
Vasodilation.
How do you keep inflammation localized to the area it needs to stay?
You have your adaptive immunity, don't you? Like your T, whatever cells they are. Is it Th17 or something? They keep inflammation in check.
The regulatory cytokines, we'll go into.
Yeah.
Yeah. So they're quite good at dampening a systemic inflammatory response. But what I mean is still on that like acute phase of like the first recognitions happen, we get this first activation of neutrophils and macrophages, first like release of all of those inflammatory cytokines. And what actually happens is like, have you guys heard of the interaction between coagulation and inflammation? So you trigger vasoconstriction. So you decrease the like ability for that infectious stuff to get out of the area initially, and you also cause clots. So you trigger coagulation. So you kind of your body's kind of walling off this infection getting in, or whatever this danger associated molecular pattern is, getting into your bloodstream.
Does it cause vasodilation and vasoconstriction simultaneously in different spots, or?
Yes, it's very interesting. So you're much more likely with the pattern of cytokines and mediators that are released to get a clot in a vein and get vasodilation in an artery. So you deliver all of those inflammatory mediators and the things that are going to help resolve the problem locally, but you're going to limit leakage and drainage from that area initially. And then a lot
Does
of
that
those
contribute to swelling if you're doing it, I suppose?
good point.
Or
It's very
edema,
much
like if
on
you.
a like capillary level.
Yeah, okay.
In theory, probably, but absolutely, like between increased vascular permeability and microthrombi within local inflammatory reactions, I would say yes, because we definitely get swelling, don't we?
Or yes, some sort of edema. Yeah.
Yeah. And then a lot of those cytokines are actually chemokines, aren't they? And they call more cells to the area, and we get amplification of that response, because then those cells get activated and then they activate more cells and then they activate more cells. So we get more inflammation. So Peugeot mentioned the regulatory pathway to stop inflammation. So you can't just have an abscess that keeps like perpetuating itself, can you? Or focus of infection. You need all those neutrophils to mop up the infection, and then you need that inflammation to go away. Can't just stay there. So then, yes, the adaptive immune system is part of it. A really big part of it, actually. So the sorry, I wrote down the acronym and not the full name, and now I'm like, oh, what is it? Stand for again? Compensatory anti-inflammatory response. So we get those typically T cells, T regulatory cells or Th17 cells, releasing cytokines that counteract and act in the opposite way to the cytokines that were released in that acute inflammatory response. Apparently, we're just it's interesting reading this chapter relative to my notes from the previous version of Edinger. And our understanding of sepsis has actually evolved quite a lot. So we used to think that we had this like pro-inflammatory response, and then we had this compensatory anti-inflammatory response, which in a lot of cases came on board too soon and almost paralyzed the immune system and made the infection worse. In the case of sepsis. And now what they're observing is that's not just like pro-inflammatory, anti-inflammatory. The course of sepsis goes like this. So if you think about those patients you've got in hospital and you're like trying to work out whether they need antibiotics or not, and they'll come in with a pyrexia of 39.4, and then they'll go down to 38.9, and then they'll pop back up to 39.2, and then they're 39, and then all of a sudden they're 40, 41, blah, blah, blah. So we see that clinically, that even without the antibiotics, that kind of fluctuation between a pro-inflammatory and that compensatory anti-inflammatory response. That is now called, that concept of like pro-anti, the mixed antagonist response syndrome. Not that that has any relevance or that you'd be expected to know that at a membership level, I would expect. Is anyone sitting memberships this year? Yeah. So most of the people that watch after the fact are the membership candidates or people thinking about doing membership and wondering what level of knowledge they need to learn. So I try and keep kind of bringing it back to the level that I would expect for memberships. But then I get excited until your fellowship starts. Right.
Or people who just love medicine.
Yeah, absolutely.
People with FOMO.
Yeah, FOMO.
That's me.
Well, you've already done it, Maya.
No, but now I'm in the eye world and I miss medicine sometimes.
Oh yeah, I can't believe you're
Get
in
my
the
fix.
Yeah, I heard you say referred it to medicine. I was like, well, that's weird.
Yeah. Yeah, I do get jealous of people I'm referring to.
Yeah. Okay, so we've talked about that kind of pathway. What about treatment? How are you going to choose which antibiotic is most appropriate? And these guys need antibiotics. If they've met the criteria for sepsis or SIRS, sometimes you don't know whether it's SIRS, but you've got a good reason to put them on some empirical antimicrobials. Obviously, take all your samples if you can before you do that. If you can, but honestly, get them on antibiotics. They need it. So what's going to influence your acute management?
I guess always thinking what is the source, like you should at least start thinking about it, and then you think about, okay, if this is the source, then what is the most likely organism, and then you target antibiotic based on that. But I always thought SIRS was actually more non-sterile. I mean, yes, non-sterile.
Yeah.
No, sorry, sterile.
Yeah. So SIRS, sepsis, we use sepsis for bacterial SIRS. Well, SIRS with bacterial etiopathogenesis, and SIRS when is just the systemic inflammatory response syndrome. So it's really the same criteria. The criteria is for SIRS, and that triggers a certain kind of pathway. But really, the causes of SIRS that aren't bacterial are pretty small, or that aren't infectious are pretty small. So pancreatitis. Anything else?
Trauma, it's like surgery. Like surgery can result in SIRS. It's trauma to the tissue.
Yeah. But there's not much else, is there? And that's a pretty obvious clinical history.
I don't know, like a GDV or something.
Thought heartworm was added to that list, but we don't see it anymore.
Not often. Yeah. It's still around, but yeah, we don't see it very often. And I don't think they present as acutely A cutworm's a chronic condition. And I'm sure they've got systemic inflammation, but they don't kind of present collapse in that setting where you need to be making decisions before really knowing what you're dealing with.
Parvovirus used to be what I considered the classic.
We haven't spoken about viral organisms, and that's a really good point. Yeah.
But the other thing that hasn't been mentioned, I think, is the necessity for shock doses of fluids.
Good. Yeah. Stabilizing blood pressure.
With the parvo cases were the ones I used to see a lot of in Riverston. It was shock doses of fluids and check the blood sugar.
Good. I love that one.
There was a practice that I visited in Canberra that they had a fairly high death rate from parvo, and I said, "Do you check the blood sugar?" And they said, "Oh no." And I said, "We better do that." And they dropped their death rate enormously.
Yeah.
Once they started dealing with that. But when I did a hypertonic saline in shock study in America, comparing isotonic versus HCl, HSL, I thought, well, let's just look at something else. What was the difference between those that lived and those that died? And the dyers, the heart rate never came down. The livers, the ones that lived, I mean, their heart rate would drop. And I found that treating the parvo cases, I'd have them on shock fluids until their heart rate started to drop. And it would come down, as you said, in a fluctuant level. It would sort of drop and then come back up. And then eventually it'd get down to 140 or below and stay there. And then you knew you didn't need any more shock fluids.
Yeah.
And that was without antibiotics.
Yeah. And that's an important point, actually, because there are infectious causes of sepsis that aren't bacterial. I wouldn't, if it's not got a typical history of parvo, like parvo is easy to detect clinically, right? Like it's a pretty distinctive presentation. There's fecal bedside tests that we can do that are relatively accurate. Whereas then I think some of the viral ones, particularly with cats, it can be really hard to know whether you're treating a systemic viral infection or a systemic bacterial infection. And sometimes we just have to use antibiotics in those situations. And we never
Is
know.
parvo often both because of the translocation from the gut as well?
That's a good point. Yeah, and they're often really neutropenic as well because of the bone marrow suppression. So they're immunosuppressed. So there could be bacterial infection from other sources or infection from other sources as well. I think it's important to note that we commonly don't identify what the source of the sepsis was. And if you get 24, 48 hours into treating one of these patients and you haven't resolved a sepsis with antibacterial medications, then you should be searching far and wide for another source. And it might, often, and like if they're antibiotic responsive, and it might have been that they trod on a splinter and got like a particularly pathogenic organism in their foot or something like that. You just often never find it. So stabilizing blood pressure is really important and really hard because the mechanisms, it's not just one type of shock, is it? We've got a little bit of distributive shock as well as like usually they're hypovolemic as well. They've been sick for a while. So there's a few different kind of mechanisms that we need to address, and you can't just turn off the inflammation and the increased vascular permeability. So managing, stabilizing their blood pressure can be really tricky.
But that's another category, isn't it? Like septic shock is another category, and those guys need pressors. They don't usually just respond to fluid boluses.
Completely agree. So what if we talk about multi-organ dysfunction syndrome? Does anyone know what that means?
Like at least two body systems are sort of involved. So there's a systemic
impact of the sepsis.
Dysregulation of the immune response in at least two body systems.
Yeah. And what are the body systems that we consider like one of the body systems that we can tick off and say they've got mods because there's two body systems? What are we looking at?
Really, like maybe liver, kidney, lungs, like
kidney, lungs, that's 3 out of 5. Yeah.
Urinary, I guess, kidneys.
Not actually on the list.
Well, I suppose
Right.
you've got kidneys
Kidneys,
on the list.
Neurological.
kidneys on the list, yeah.
I think cardiac and circulatory.
Right, yes. So for me, I don't think of like hypotension as a body system, and I find it hard to remember that's one of the categories. But if they're hypotensive as a result of SIRS, that's one body system ticked off.
Oh, okay.
So if they're requiring vasopressors, not just fluid boluses, they've ticked that box already. And then what markers on your blood test would you look for to demonstrate hepatic dysfunction or to tick the box of hepatic dysfunction?
Albumin, that's more chronic though.
More chronic. So we're
Yeah.
in very acute presentation.
What, maybe T-bill?
Yeah,
Yeah,
but
it's T-bill. It's T-bill. Yeah, it's the only one.
Which one, sorry?
T-bill,
Bilirubin.
total bilirubin.
Oh, okay.
So if it's above 8.6, tick the box.
Oh.
And I reckon we see that in cats really commonly with systemic inflammation.
Yeah.
They love making their bilirubin go up. So that's a box we tick often in cats, not as often in dogs in my experience.
Mm.
But then
What
again,
about
Anna, with the elevation, because sometimes you run bloods and your T-bill is sitting at if your range is like 14 and T-bill is like 16, 17, meh, that's not really how much do you,
tick the
but
box?
you have to take it in context with the presentation, right? Like what the presentation is and what level the
Yeah.
elevation is. But there's
And
no,
how much
I can't, I've looked this up multiple times. I've never really found anything not exactly number, but at least like a range that this is more likely, this is more likely, it is, unless you have some other ideas.
No. Bilirubin I find actually quite a vague test.
Yeah.
And it's often just a little bit elevated. I'm like, I can't
Yeah.
really explain that.
How much importance do you pay to that then?
Yeah. Depends how much detail I want to put in my report. Sometimes I just ignore it. But
Unknown significance. I like that.
unknown significance, exactly. Yeah. Part of systemic presentation. What about renal? How do we detect renal dysfunction with systemic inflammation?
Increase in
Yeah, I guess.
Yeah, exactly.
Even if it's still within the reference interval.
Good.
Baseline.
Yeah.
I didn't
Just
hear
hard if you don't have
what that
reference.
was.
Sorry, Jeff.
What was the method of detecting it? I didn't hear it.
An increase in creatinine
Oh, okay.
over time. So that relies on us doing serial blood tests, doesn't it? Or having a baseline of this patient before it's presented. And recently as well, because we get to decline in renal function, you can't look at a blood test from 5 years ago and say the creatinine was this then, and therefore it should still be this that now. So a change of 44 is considered, or above, is considered you've ticked the renal box for organ dysfunction.
What about the
your-
pre-renal factor then though? Can you only measure that once they're like
so that's
rehydrated euvolemic? Like
pretty much. Yeah.
What about urine output?
It's not one of the criteria because it's so variable.
Right.
But yes, absolutely. And the earliest mechanism or the earliest way that we can detect renal dysfunction is actually appearance of cast. So if you've got a patient that's had like a nephrotoxin or something like that, or you're having to treat them with gentamicin or something, they're an at-risk patient, but they've got normal creatinine. If you all of a sudden start getting casts in their urine, that's one of the earliest ways that we can detect renal dysfunction. So we should talk about anaphylaxis quickly. Is there any other? Oh, coagulation was the other system. Sorry. It's my favorite of all the systems. But again, it wouldn't fall in my category of a system.
No.
When I was just thinking off the top of my head. So it's important to have like a list of things that you go, yep, tick, 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 tick. So great if the APTT and PT are greater than 25% above the reference range, then you've got dysfunction of the coagulation system, and it can be one or the other or both to meet that criteria. What about platelets? What do we see with sepsis quite often with platelet numbers?
Oh, they decrease dramatically.
Yeah. Yeah, absolutely. So they get consumed, don't they, in the process of those little microthrombi we talked about. So we get a consumptive thrombocytopenia, and if it's under platelet count's under 100, you've ticked that box as well.
Yeah, Ava Firth used to say she was looking at a slide and the platelets suddenly disappeared. She knew she had a problem.
Yeah, big problem. Okay, 5 minutes for anaphylaxis and hyperthermia. Does anyone have anything specific they want to cover in these categories?
Just a comment, anaphylaxis, again, like systemic anaphylaxis can present in any way, in the sense they can come even as a heme abdomen, and then you get the history and it's bloody anaphylaxis.
Yep.
But
And then-
cats, what about cats? Have you seen systemic anaphylaxis in cats? Because again, that's not something I've heard somewhere that cats actually die before they come with
Yeah,
systemic
because
anaphylaxis.
they get respiratory,
Because the lungs are it's a
like
shock
us,
organ
right?
for
They
them.
get
Yeah,
bronchoconstriction, they just die.
yeah. But that's what, like, has anybody seen in a cat systemic
not
anaphylaxis?
community acquired anaphylaxis, but definitely hospital acquired anaphylaxis.
Yeah, okay.
Yeah. So tick serum, we see it quite often, unfortunately. The cats that have been exposed before will often have an antibody response all ready to go, and they'll have systemic anaphylaxis as a result of that, and it's pretty spectacular. And you can't really treat tick paralysis without tick anti-serum, so it's not really any other options other than giving it.
That's why they have a new one for cats now, or at least a while back they were without that albumin, because that's the
one of the triggers.
there's a different one for cats, safer.
Yeah. We use the purified one for cats, to my knowledge. Again, I'm not in a clinic at the moment that treats tick paralysis, so I'm probably out of touch, but I'd be very pleased if there's one that is less likely to cause anaphylaxis. So what might we see with anaphylaxis in a cat? Lungs.
Respiratory distress.
Yeah, pretty much. So we've had patients that with their anti-serum, their lungs they'll have normal respiratory function, and then they'll have completely flooded lungs, and they'll have water and blood pouring out of their airways. It's just so dramatic, and like we obviously intubate them pretty urgently, and adrenaline and all of that stuff, and there's blood coming out of the tube. It's just all of their blood vessels walls just disintegrate basically. Very dramatic. Let's talk more about dogs, because I think that's a more common clinical presentation, is community acquired anaphylaxis. Most common cause of anaphylaxis in the community?
Bee
Feasting.
Yeah. Bees and wasps, and similar, if they've reacted to a bee before, they might react to a wasp next time. Doesn't have to be the same. What's the mechanism of the reaction?
IgE mediated, isn't it?
Yeah.
Hypersensitivity.
Yeah, exactly. So it's a hypersensitivity reaction mediated by what cell?
Mast cell.
Cells, good. Yeah. So typically, the mast cells degranulate and they release what?
Histamine.
Histamine.
Yeah, and like platelet,
Histamine.
a bunch of pro-inflammatory cytokines and stuff. And then what happens?
Vomiting. The histamine.
Yes, good. So that's the most common. So 98% of dogs will have gastrointestinal signs in their history. 94, sorry. And yeah, so like 3/4 of cats, 74% of cats. What else might we see?
Like this, then cutaneous form is the most common.
Yeah. And redness, urticaria, pruritus, agitation, all of those things, acute onset. How often do we see respiratory signs in dogs?
Not that often, I would think.
It's quite amazing, actually. I always think it's going to happen, and like even the dogs with like massive heme abdomens and stuff. Like, no, you're breathing really well. It's weird.
Because I think the shock organ is different in dogs. I think it's liver and gut for anaphylaxis, whereas cats is lungs.
Yeah, exactly right. So how are you going to make a diagnosis these dogs probably meet all the criteria for SIRS, actually. Like they're often tachycardic. They're often got
Yeah.
weird white blood.
Hypertensive if they're crashing.
Yeah, exactly. Yeah. So how would you, like, obviously history might give you an indication, like they were outside, they vomited, then they collapsed. That's a bit of a nice kind of hint. Clinically, what would you do when they're wheeled in on their trolley
Air
collapse?
first.
Yeah,
Check the gallbladder.
good. Yes, excellent. And why are we checking the gallbladder? What will we see?
Gallbladder halo from edema around the gallbladder.
So that happens because of a combination of vasoconstriction and vasodilation and increased vascular permeability that comes from systemic inflammation, and specifically from the IgE or histamine mediated reaction. So we also see markers of portal hypertension. So you might see congestion of the spleen and things like that as well. What is the mechanism for heme abdomen in these cases?
I just thought it's like vasculitis and then like the
Pretty much.
fluid leaks out.
Yeah. So essentially it's just destabilization of the vascular membranes and increased vascular permeability, but then actually portal hypertension, that very acute portal hypertension also contributes to it. So whilst it's a heme abdomen often, and I know we've talked about this recently in our effusion section, the PCV is never quite as high as the blood PCV. That can be a hint whether your heme abdomen is surgical or not. If the PCV is lower than peripheral blood, you can say, it's probably an increased vascular permeability mechanism. I should be looking for causes of increased vascular permeability. All right, how do we treat it?
Bolus, fluid boluses. And it's just supportive treatment typically.
Any medications?
You can give. I've never used it, but like people do use norepinephrine, but I've never needed to. I've like with fluids, they've usually responded.
Steroids as well.
And then you can give histamine, like I mean antihistamine, not histamine.
I think this is a really interesting discussion because I've never met a clinician that's very pro adrenaline or like noradrenaline in these situations, but the evidence is pretty clear. I don't know why people are apprehensive about using it. So in humans, like standard of care, obviously it's much more urgent because the airway is the shock organ in humans and we tend to get upper respiratory obstruction. But the benefits of adrenaline in these cases are like sort of across the board. I've made a list. Decrease mast cell release of the mediators, so it decreases perpetuation of that reaction. Vasoconstriction, so it improves your blood pressure. Positive inotropy and chronotropy, so improves cardiac output. Bronchodilation and decreases mucosal edema. So if you are getting any airway swelling, particularly in cats, very, very much indicated. So it definitely stabilizes the blood vessels as well, so less vascular permeability. So there's a lot of benefits to it and really very few risks with it. Like it's something that obviously they're going to get tachycardic. You're not going to make their blood pressure worse with it. They might feel a bit yuck, but it's going to be out of their system within a few minutes, really. It's not going to have lasting effect. So if you don't see any benefits, you don't have to repeat it. And the evidence says that a bolus is less effective than a CRI. So often we sort of start with a bolus and then do a CRI, but if you're doing subsequent boluses, it's less effective than just the CRI.
Yeah, what dose would you use?
I don't know. I'd have to look it up. Probably the low dose on that crash cart.
Yeah.
Oh, that has
I think
changed.
we're just not used to using
recovered.
it until things are actually dying. That's why, like, I'm just not comfortable with it because we don't use it until things are, you've got nothing to lose. Because
yeah, agree, because it's like it's very much an emergency drug for us, but this is like this is the indication for it.
yeah, no, absolutely.
I mean,
yeah.
it is an emergency, obviously, but
With the
Interestingly,
CPR guidelines digressing, but with the CPR new guidelines of recover,
There's
this
no high dose.
high dose epinephrine is out the window. It's only
Yeah, I
one.
noticed that.
interesting.
couldn't
Well,
find
I
it.
think CPR is next, so we will discover this next chapter.
Right.
So we do need to wrap up, but antihistamines and cortisone or steroids, there's actually no evidence for efficacy in an acute setting. So steroids have delayed onset of action, so 24, 48 hours at the earliest. So the reaction's done by then. By the way, and antihistamines in theory have good, like it's a good idea, but it's too little too late typically to actually stop manage the effects of the reaction that's already happened.
I would say that in general practice, the majority of ones you see, ant bites and bee stings and things, you get edema of around the head and not much else.
Yeah,
And,
that's a typical
and-
reaction.
And in my early days, one practitioner said, well, they get better in half a day if you do nothing, and they get better in 12 hours if you treat them.
Yeah. So anaphylaxis, we're talking about systemic anaphylaxis, whereas that
Yes, yeah,
local
I get
reaction rather than
that's right, and that's more likely to end up in an emergency unit than is the
The collapsed dogs are much more rare for sure. And I think because we see this facial swelling, we correlate that with human throat swelling, but actually the humans having throat swelling having been stung on the hand or the foot. So that for them, it's a systemic reaction. Whereas for us, the dogs got stung in the mouth, and that's why they're swollen up locally. So it's actually a local reaction, and they're not actually at increased risk of airway obstruction unless they've got like no airway and their swollen cheeks obstruct what they've got left.
And then ALT will be high because that's why systemic anaphylaxis is not on DD list for a lot of people. But like that's another like thing to think. ALT will be high because of the congestion.
Up to 10,000.
Yeah.
Wow.
Yeah, I'd be pretty alarmed and be considering hepatitis as an cause of acute vomiting in that patient. But
Why did you say it was high? So high?
why?
Yeah.
It's actually permeability. So the blood supply to the liver just gets cut off completely, and all the liver cells just go, oh.
It's almost too high to be hepatitis, isn't it? Like it's that's
so
so
high.
high.
But then it can also be completely normal until 24 hours after, and then go up. Like it's actually a little bit unpredictable in the way it will behave. All right, I've got to run. I've kept you over time. Sorry.
Thank you.
Right,
Thank you so much.
Thanks, everyone.
Bye.
Bye.
Wait, I'm away. We're skipping a week. Sorry.
Okay.
Right, is that next week?
Email us.
I'm away in 1 fortnight, and then we'll be back a fortnight after that. So we've got a month before CPR.
Right. Have a good month.
Have a good time
Okay.
away.
Have a
Thank
good day.
Thanks,
Bye.
Anna.
Guys.
Thanks, Anna.
Cheers, Jeff. Bye.